It's yet another complication of coronavirus. The disease is causing severe inflammation in the lungs and blood vessels, a natural response of the body to the virus. The virus causes blood to become more sticky, which causes blood flow difficulties in the lungs with low blood oxygen levels, and later can lead to fatal blood clots.
What time we start? We started at 2:17.
Those people are also then being immobilized and on ventilators. That stickiness of the blood is also going to cause deep vein thrombosis. So this is more like in the leg veins, in the abdomen there's problems being reported. And if those thrombi in the leg veins get dislodged, they'll shoot back into the lungs through the pulmonary artery. Now you have a blockage not only on the exit side of the system, but also on the entry side of the system. And that's going to cause even more problems. And that's where basically the reserve that somebody normally has gets overwhelmed, and that's when people can die acutely. And that's what we've seen in the high mortality rates in intensive care patients. It's not just the ventilator not being able to keep up, but also these people having both early onset clotting disease in the lungs themselves, and then also on top of that, get pulmonary embolism. And that's quite often has been a fatal event, or you see these patients deteriorating very rapidly, sometimes just turning the patient, and all of a sudden they would more or less die on the spot.
A pulmonary embolism is caused by a blockage of an artery in the lungs by a blood clot that has come from elsewhere in the body. But doctors have found that blood vessels are also affected, which may explain the wide range of COVID-19 symptoms, including blood clots.
The figures are that people in an intensive care setting, if you think 30 to 50% have pulmonary embolism, it's around 5% of patients who will have a stroke. Now, of course, a lot of these patients are elderly, so they may already be at risk of a stroke, but it's more than what we would normally expect to see in an intensive care situation. The same is true for pulmonary embolism. It's a higher ratio of what we normally expect to see in an intensive care situation.
So how do doctors and scientists identify these possible problems, and how can they treat them?
We've seen that the D-dimer test that I mentioned earlier, that's a sign of increased clotting. Now we know that the D-dimer test isn't perfect, but we've used it for a long time in trying to identify people who have symptoms in the lungs. Is it pulmonary embolism, is it not pulmonary embolism? And we've been able to use that as a marker and sort of a cutoff. So if it's low, then the chance of you having increased clots in your bloodstream are not really very likely. If it's higher, then it's going to be more likely. What we've seen there is that from the Wuhan data, that if the D-dimer levels are much higher than we've ever seen before. So there's an awful lot of thrombosis going on in the blood vessels. If you have low levels of D-dimer, obviously you do not have this problem so much. And as it turns out in the Wuhan data, if you have these high levels of D-dimer, is a prediction of people dying. If you have low levels of D-dimer, is a prediction of you going to survive. So it's a massively important test in that respect. Once we started looking into this, the intensive care physicians looked at this for over a 1 week period. They had about 45 patients in intensive care, and about 35 of those patients had high levels of D-dimer, and then they tested them and they all had pulmonary embolism. And the ones who had low levels of D-dimer, none of them had pulmonary embolism. So it was a direct discriminator and direct pickup of what was going on. What we suggest is that if you have low levels of D-dimer, what you should do is just do normal prophylactic anticoagulant treatment. This is with things called heparin type drugs. Interestingly, in Germany, they've always had higher prophylactic doses, and they have the best outcomes in the whole world in terms of intensive care treatment. So there's something that sort of suggests that may certainly be working.
Are we seeing a rise in how many people are making it through the ICU? If you know this information now, because earlier on it was about 50% of people were making it through the ICU. Has that changed?
So what we saw was what we call an over-mortality in patients with COVID compared to what we normally saw in intensive care units. The report we wrote was for the Public Health Ministry in the Netherlands. Since we issued the report on the 9th of April, in the meantime, they were looking into this D-dimer level, and they started testing because we had the discussions at the end of March. And reports have come out of Holland, the high levels, 30 to 50% of people had pulmonary embolism. Since that, they've shifted, so they basically are doing this D-dimer monitoring. They are giving more anticoagulation. They are testing more. And what we've seen is a mortality that's now normalized for what you'd expect in an intensive care situation. So the over-mortality that we were seeing, and like you say, people 1 in 3 to 1 in 4 people were easily or even more were dying. We've now seen that is sort of normalized to what you normally see in a normal intensive care setting. So it's not like multiple people dying on the same day in one intensive care unit. People still die, unfortunately, but it's certainly dramatically improved. 1 in 3 to 1 in 5 of these patients had pulmonary embolism, which were now adequately treated, and therefore you can expect to see an improvement